Dr. Mark Timmerman, and I would like to go over the marking and the palpation and injection of the knee. First, let's approach the knee from an intra-articular injection. Several ways to do this. You can do this from a 90-degree angle, which is a popular technique for approaching the joint capsule. Okay. Let's start with the intra-articular injection of the knee. Important structures to palpate here will be the patellar tendon, medial border, and the lateral border. And one approach is to use the medial aspect, and the other approach is to use the lateral aspect at a 90-degree angle. Injection-wise, and we would use a 25% solution of dextrose normally, about 5 cc's, with the needle oriented toward the midline and in the plane of the femur. You inject straight into the joint capsule, and likewise you can do this from a medial aspect, moving toward the midline and in the plane of the femur with the orientation of your needle. Alternatively, one can place the knee in a relaxed position and mark the superior border of the patella and use either the superomedial or superolateral patellar approach. In this case, it's important for the patient to be quite relaxed so that you can blot the patella, which allows the passage of the needle underneath into the joint capsule. So if you're using the lateral approach here, you blot the patella toward the needle and then place the needle at about a 45-degree angle until it slides underneath the patella and into the joint capsule. Or some people prefer the medial approach, and likewise with the knee cap relaxed, you blot the patella toward the needle and the same 45-degree orientation sliding underneath the patella into that patellar pouch. A couple of points to remember. One, if you introduce the needle and you move the patella and the needle moves with your movement, then you're on the patella and need to go deeper underneath that patella. Also, if you start your test injection once you're into the joint capsule or once you feel you are into the joint capsule, an injection into the capsule will not be painful. If the patient experiences discomfort with the test injection, you're likely in soft tissue and need to introduce the needle further into the capsule. Let's approach the medial knee, starting with the femoral condyle, marking where the medial collateral ligament attaches, and then where it has its broad attachment on the anteromedial tibia. Also, an important structure is the joint line, of course, where the medial meniscus attaches and where the coronary ligaments form that attachment to the tibia. Also, the broad area of the pes anserinus, here, where the sartorius and the gracilis and the semitendinosus tendons attach through that area. When you palpate the medial knee, And this is crucial to perform specific one-finger palpation technique to determine where the patient is tender. So, for instance, if the patient is tender along the medial collateral ligament, you would mark those areas of tender palpation. Once again, along the medial joint line and coronary ligament. And often, there will be many tender areas that one can palpate and mark throughout this pes anserinus attachment area. From an injection standpoint, and once again, it's helpful to have the patient relaxed so that you can move soft tissues away from the bony structures. Remember, we're injecting only on bone, and an important technique to remember is to palpate and then move the soft tissues away from the bone so that you're injecting right on the bone, for instance, the medial femoral condyle here. And with deliberate injection technique, sliding soft tissue away from bone and injecting on bone, you can move through the fibers of the medial collateral ligament, and then once on the joint line, especially where the coronary ligaments attach, with an angulation down toward the tibia, multiple injections along the medial joint line in those tender areas. One can proceed to the palpated tender spots, peppering this rather large area with multiple injections of dextrose or your injection solution. Important to keep in mind that the pes anserinus attachment area is not just a bursa, as many of us learn in medical school, but rather this broad attachment of the semitendinosus and gracilis and sartorius muscles. And it often, even if you're careful to palpate, will incorporate an area that can be surprisingly large. Once again, multiple injections through this broad attachment area is often necessary to cover those tender attachment points. Now let's approach the patella and the important structures there, including the patellar tendon or ligament attaching to the anterior tibial tubercle. And often, especially in the case of a subluxing patella or patellofemoral pain, the ligaments of the retinaculum on the medial aspect of the patella. Palpation includes, once again, with the patient relaxed, one can blot or tip the patella toward you so that the face of the patella is toward the palpating finger. And injection areas here then would be the distal pole of the patella, and often in the case of patellar tendinitis, the attachments on the anterior tibial tubercle. Injection-wise, in a similar fashion, holding the patella toward you so that you have a broad face of that inferior pole, one can inject several areas, peppering this inferior pole of the patella where the ligament attaches. And then changing orientation, once again with a guiding hand or thumb firmly on the area near your injection onto the bone at the attachments on that tubercle. In a similar fashion for the medial patella, by ballotting the patella medially and palpating a structure, sliding the soft tissue away, one can inject right over that guiding finger so that you always have contact with the patient, helping to guide the needle and provide proprioception for your injection. Let's approach the lateral knee, where, as on the medial aspect of the knee, the femoral condyle is an important structure to identify. Here where the lateral collateral ligament attaches and carries its course down to the head of the fibula, like this. Also, an important and often forgotten structure is the tib-fib ligament here, which can be the cause of fibular instability and pain. And as for the medial knee, identifying the joint line where that lateral meniscus is attached to the tibial plateau by the lateral coronary ligaments. Palpation, once again, is done with a specific, deliberate one-finger technique, and if the patient is tender, identifying those tender areas like so, remembering that the lateral collateral ligament attaches posterior to that condyle, not anterior to the condyle. So it is important to get essentially behind that condyle to identify those trigger points. Patients will often be tender along those coronary ligaments on the joint line, as well as the head of the fibula, or as I mentioned, the tib-fib ligaments. Important to remember, of course, that the nerve runs posterior to the fibular head, and so we will stay superior and anterior to the fibula. And in some people, it's hard to palpate the joint line, and one can use the inferior border of the patella as a rough guide to that joint. From an injection standpoint, once again, it's important to palpate and press away soft tissue with direct contact with your target area and inject onto bone in the areas that you've identified as tender areas. Once again, being careful to get behind this lateral condyle, working down to the joint line, and then approaching those coronary ligaments using an inferior orientation of your needle at that joint line. I think it's important to place a finger or a thumb over the head of the fibula so that you know that if you're injecting on top of that, you cannot injure the nerve which lies below. So you'll be safe by palpating, sliding, and injecting the head of the fibula in this fashion. And one can continue into those tib-fib ligaments on the fibular aspect and then change the orientation to angle more into the tibia to get the tibial aspect of the tender areas on the tib-fib ligament. Now one can do these injections also if you prefer, in a 90-degree angle with the knee. Some practitioners find it comfortable to inject with this orientation. It's simply a matter of personal preference. The anterior cruciate ligament can be injected from an anterior approach by identifying once again, the border of the patellar tendon and the tibial plateau, and injecting down underneath that patellar tendon or ligament, because the ACL attaches underneath it at that top of the tibia. So injection-wise, you would approach as you would the intra-articular injection, but angling the needle more inferiorly and underneath the patellar tendon until you feel the ligament tension as you inject down on the tibial plateau. Likewise, with the superior ACL attachment at the medial border of the lateral condyle, one can use the intra-articular approach to inject into the capsule and toward that attachment on that medial aspect of the lateral condyle. For the posterior cruciate ligament attachments, one can use the crease of the posterior knee as a guide for the joint space, and deep palpation will allow you to feel that tibial plateau. Once again, one can slide the soft tissue structures away, keeping the tibial nerve and artery safe, and injecting down onto bone on that tibial plateau. Likewise, that lateral aspect of the medial condyle can be reached by pressing soft tissue away and marking that aspect of the condyle with an injection to follow in a similar fashion at the posterior cruciate ligament attachment. Let's use a model to identify further our injection areas. We first did an intra-articular injection with the right knee, in this case, in a 90-degree position, using either the lateral or the medial border of the patellar ligament, injecting into that joint capsule with the orientation of the femur. An alternative technique, once again, would be to ballot the patella upwards and slide underneath. Once again, if you move the patella and the needle slides with it, you need to reorient and go down into the joint space. This can be done from the lateral aspect as well, relaxing the patient, moving the patella up, and sliding into the capsule underneath it. Patellar injections, once again, are done by ballotting the patella up toward you so that you can angle your needle into that inferior border of the patellar attachment of the patellar tendon. Likewise, one can inject the anterior tibial tubercle in that fashion. The medial patella we injected by forcing that medial border up toward the needle and multiple injections on those medial retinacular attachments of the patella. The medial knee, once again, with the true medial collateral ligament attachments really behind this condyle, the injection technique is to push the soft tissue away and inject onto the bone, injecting right over your fingers so you know where your needle is landing, and proceeding down through the tender areas of the medial collateral ligament and to that medial joint line. We discussed those coronary ligaments which attach the medial meniscus to the tibial plateau with an orientation in an inferior angle, multiple injections on that usually tender medial joint line area. And then one can extend down into this broad attachment of the medial collateral ligament and the pes anserinus muscles, which will represent itself as multiple tender areas along that anteromedial aspect of the tibia. Remember that this pes anserinus area is not a bursa, but an extension of ligament and muscular attachments which can go a surprising distance down the tibia and encompass a surprising amount of that anteromedial tibia. Injections to the lateral aspect of the knee once again include that posterior femoral condyle laterally, where this lateral collateral ligament starts its attachments, and then injecting along that lateral collateral ligament to this joint line, where, as on the medial knee, the coronary ligaments extend almost to the center line, attaching that lateral meniscus to the tibial plateau. Once again, important to palpate the tib-fib ligament. It is often tender and can be a source of laxity. And with the thumb on the head of the fibula, one can press the soft tissue away, keeping the nerve underneath the fibular head safe, and injecting along the fibula and along the tibia at the attachments of that ligament. So injection of the anterior cruciate ligament, once again, this is the right knee, so one would approach the medial aspect of that patellar ligament and angle down at the ACL attachment here. And then the femur attachment is the medial aspect of the lateral condyle, using your intra-articular approach and extending to that condyle at the attachment of the ACL. One can also inject the posterior cruciate ligament from the posterior aspect of the knee. This is an advanced technique due to the popliteal artery and nerves which run through the popliteal fossa. But if you're careful to push soft structures away and inject on bone, one can inject the distal attachment of the posterior cruciate ligament on the tibia, and likewise, angling to the lateral aspect of the medial condyle, the posterior cruciate ligament is in the posterior aspect of the condyle.